All right, so today we'll be talking a little bit about jaundice, and in particular, we'll describe the potential causes of high bilirubin and its accompanying clinical features that can help distinguish between different causes. We'll talk a bit about investigations on jaundice and abnormal liver function tests, and outline the role of imaging in the investigation of jaundice. So these three pictures illustrate potentially jaundice, but one of them is not jaundice. Do you guys know which one? Well, the first picture, you can see the discoloration of the face and jaundice. The second one is a little bit more mild. It can be seen in the sclera, scleroictris. And the third one is more involving the palms and soles or palms of the hands. Well, jaundice can actually also involve the palms of the hands in a severe state, but if it is affecting the palms at a quite early stage, we need to consider the possibility of whether this might be something else, which is always a possibility. And in this case, it's actually carotenemia, and we'll talk a little bit about what it is soon. So, what causes jaundice and what is it? Well, jaundice is the yellowish discoloration of the skin, and really it's an elevation in the bilirubin levels, more than 3, to be exact. And these deposit in our skin and gives off that yellow color. And the thing is, it reflects underlying diseases that could be secondary to whether that's intrahepatic or inside our liver or outside to extrahepatic. And the causes are relatively quite equal. So before we start to understand a little bit about the causes, it's really important to go about how bilirubin is made and what happens to it in our body. So our red blood cells stay in our circulation for around 120 days, and it breaks down in our reticular endothelial system, such as our spleen, where it gets broken down into hemoglobin. The hemoglobin component of the red blood cell breaks down into heme. And while the globin gets recycled for amino acids and reused for protein synthesis, the heme component breaks down into iron, again, reused by our bone marrows or stored in our liver or our spleen, or it could be broken down to biliverdin. So biliverdin is actually a greenish color, and this then can be quickly converted in our reticuloendothelial system into bilirubin. Bilirubin is then, or we call this unconjugated, so this is lipid soluble, and it's transported in our blood either freely or bound to albumin, and is then taken up by our liver. Here, it goes through a special process called conjugation with glucuronic acid. And this process makes it water soluble. And that's a very important aspect because we'll talk about why it is. And this is secreted by the bile and then excreted in our feces or urine ultimately. This next diagram really illustrates how it's secreted. So bilirubin goes down into our small intestine, gets converted into urobilinogen through the small bacteria in our gut. That could be reuptaked into the systemic circulation and either could go through an actual cycle of its own over here, or can be converted to urobilin in our kidneys, giving off the yellow color. And in terms of stercobilin, urobilinogen can be converted into stercobilin through the intestinal bacteria in our gut, and then can excrete it through our feces. And that actually gives off the brown color of the feces. So if there was any abnormality in the bilirubin over here, so if the conjugated bilirubin could not exit through the small intestines, then it cannot really be converted through that whole process, and therefore there'll be an absence or reduced amount of stercobilin, so the stool will have a more pale color. That's a very important thing to consider when we are looking at patients with pathologies in this. So in terms of jaundice, there are three things we should think about. Well, first of all, is this really jaundice? Because skin changes similar to jaundice can occur in Addison's disease. It can occur in anorexia nervosa. It can even occur when there's ingestion of beta carotene. So we'll call this carotenemia. And this is really due to, so beta carotene can be found in lots of different types of vegetables, especially so carrots, sweet potatoes, leafy vegetables. And patients consuming a large amount of this can actually have an overload of beta carotene. Furthermore, in thyroid disorders, thyroid hormone is very involved in the conversion of beta carotene to vitamin A. So this is actually a precursor to vitamin A. Hence why we say carrots possibly is good for your eyes. I'm sure everyone's heard that saying. So when there's an absence of the maybe thyroid hormone, there could be a buildup of beta carotene, and they can lead to discoloration, especially in their palms and hands, and can involve the skin as well. The best way to actually differentiate between jaundice and carotenemia is just having a look in the eyes, because jaundice affects the sclera as well. Now, in terms of jaundice, two big separation. There's unconjugated hyperbilirubinemia, which means there's too much bilirubin presenting to the liver for conjugation, and conjugated hyperbilirubinemia. So in terms of unconjugated, there's two big processes. So this is too much bilirubin coming to the liver saying, I want to be conjugated. Well, where's it coming from? Well, remember how bilirubin's formed? Red blood cell breakdown. So either there's a lot of red blood cells breaking down, or there is a problem with the conjugation. So they're coming to the liver, but the liver's not able to really change that process into conjugated bilirubin. So that's two ways of what's causing it. Conjugated hyperbilirubinemia, it's a very mouthful to say, could be due to intrahepatic or extrahepatic causes. So it could be due to an insult to the liver itself, and it causes a release of all this conjugated hyperbilirubin, like bilirubin inside the liver, ready to be exported into the bile system. Or there's a blockage in one of the ducts. So if we think about it this way, it makes a lot more sense. So we can always think about it, if it's coming to the liver or not being able to process, all unconjugated. If it's insulting the liver or outside the liver, we're going to have conjugated. So here's a better breakdown of all the different causes. So what causes red blood cells to even break down? Well, autoimmune anemia. There could be hemoglobin disorders, enzyme disorders. So things like G6PD is an enzyme found in red blood cells, which is protective against oxidative stresses and antioxidants. So when there is especially things like some sorts of beans, like flava beans, or certain types of medications, can cause oxidative stress to the cells. And patients that have a reduced enzymes, especially G6PD, are more likely to have hemolytic anemias. Red blood cell membrane disorders, there could be myeloproliferative disorder like polycythemia vera, causing a lot of red blood cells to be broken down. There could be a disorder with the conjugation process, so especially this enzyme. The most common one is actually Gilbert syndrome, which is actually relatively benign. So these patients have a reduced level of these enzymes, and when they have in states such as fasting or strenuous exercise, or when they're quite ill or under stress, the liver is not able to conjugate that bilirubin quite well, and they have actually an elevation in their bilirubin. But generally, they operate just fine. On routine bloods, their bilirubin will be slightly elevated, but all their liver panels will be normal. The other one is actually a bit more severe sort of Gilbert syndrome, and one of the types can actually have an absence of this enzyme. So if it's a conjugated elevation, so liver source, what's causing the liver to be insulted? It could be viral, alcoholic, it could be a fatty liver disease, a drug-induced disease, sepsis, autoimmune, a bit more uncommon, Rare ones like primary biliary cirrhosis in more middle-aged females, or autoimmune hepatitis. Ischemic hepatitis, mass lesions, because malignancies could be primary or secondary spread, or genetic. It could be a copper deposition disease, such as in Wilson's disease or iron. Now, outside the liver, there could be a blockage. And what could cause a blockage? Stones, could be a stricture, cysts, cancers, tumors, and even infections could cause this. So it's always good to have an open mind. So when we're talking to a patient, we need to have a good history. We need to get an association of their pain. And when they're having painless jaundice, especially with like other symptoms such as weight loss, fatigue, poor appetite, we need to really keep malignancy in the back of our mind. If there's abdominal pain, it really could be a wide range of differential diagnosis. So acute hepatitis or chronic pain could be even related to malignancies, but really has a wide range of differentials. Past medical history, so if some things can repeat itself, if they have gallstones in the past, they might present with another one later down the track. Cancers, when you think about whether it's spread or chronic pancreatitis or anything like that, can cause strictures in the future. Good social history, so travel, food ingestion, thinking of like viral hepatitis. Again, if they have multiple sexual partners, it's important to screen them for if there's a viral hepatitis. Alcohol, cigarette, IV drug use, and any new medication started that could be possibly toxic to the liver. Family history is also a very important one, especially when thinking about malignancies. Physical exam, so do your thorough abdominal exam, and things that you might find is encephalopathy and very chronic liver disease. Other signs of chronic liver disease, especially peripheral signs, could be some bruising. There could be some spider nevi or angiomas. And look, if you find one, it's not abnormal. You have to find, I think, at least 5 before it's abnormal. And palmar erythema, these all represent estrogen buildup due to their liver not being able to metabolize it properly, especially with gynecomastia in males. Hepatomegaly, splenomegaly, check for any tenderness. And if the liver is impaired or quite seriously diseased, you could find ascites, which is a buildup of fluid in the peritoneal cavity. What are we going to order for bloods? We want to find a full blood count and a blood smear. We're going to try to see if there is any sort of anemia going on that could cause our jaundice picture. We want to have a look at coags, which could really identify the function of our liver. Our liver function panels, including fractionated bilirubin, of course. And if suspected on clinical history, or if the above investigations are unclear, it's important to consider a hepatitis panel or an autoimmune panel looking for autoimmune hepatitis as well. In terms of imaging, ultrasound is usually our first line. It's cheap, it's non-invasive, and it's easy to use. It does have its limitations in terms of visualizing it, but it's our first line because it's something that's relatively easy to do. And it can help give us a good idea of whether there is any obstruction, and gives us a good imaging of the liver itself. If you really want to evaluate the intra and extrahepatic biliary tree, we can consider an MRCP or an ERCP. ERCP has the added advantage of diagnostic and even therapeutic role. So if there is an obstruction, there is some roles to relieve it. For example, if there's a stone, there is able to remove the stone. An MRCP is used for visualizing. Here's some pictures. As you can see, here's an ultrasound of the liver with dilated extrahepatic ducts and intrahepatic ducts as well. And you can see the liver around the sides, possibly due to an obstruction of some sort. Here is an MRCP. It's a more detailed view of the biliary tree. Here, our right and left biliary hepatic ducts coming down to a common bile duct. We can see a pancreatic duct, a cystic duct, and our gallbladder itself. And the filling defects represent stones. So you can see some stones in the gallbladder and even towards the distal end of the common bile duct. And D stands for duodenum. So my laptop's actually going to run out of charge. I'm just going to plug it in to the charger. Wonderful. So if all the initial investigations are unclear, then, and if a biopsy can make a difference in terms of treating it and determining prognosis, then it should be definitely considered. So here's a good flow chart to go through. So perform your history, your labs, and if it's normal, then consider other causes for the jaundice. If it's unconjugated, look for a peripheral blood smear. You can even order some direct antibody tests or even test for any enzyme disorders as well. And if there is, if it's the unconjugated bilirubin's a little high, but everything comes to be normal and you ruled out hemolytic anemia, then consider whether there is an enzyme issue such as Gilbert syndrome. If the conjugated bilirubin is high, then order some viral studies and consider imaging as ultrasound first line. If the viral comes back positive, there you go, you've got a bit of an idea as well. And if the cause is identified through ultrasound, then treat it as usual. If there isn't any identified diagnosis yet, then we might need to consider some further analysis, such as cancer testing, biliary imaging, or whether it might have to add in some autoimmune screening. So let's do a case study together. This 42-year-old woman presents with 24 hours of severe epigastric abdominal pain radiating to her back with several episodes of nausea and vomiting. She's had some similar painful episodes in the past after following heavy meals, but they always resolved within an hour or two. But this time it didn't improve, so she wanted to seek some help. No medical history, no medications. She's married and has 3 children and does not drink alcohol or smoke cigarettes. So in this history, take some time to pause and think about what's happening. So in this case, it sounds like she has some gallbladder issues, especially with pain following heavy meals lasting an hour or two, but resolving. Sounds like biliary colic. But the fact that it didn't improve and this pain is now radiating to her back sounds like it's obstructing the biliary tree. And in this case, it sounds more like acute pancreatitis. If for gallstones, there are actually 5 F's that students remember or memorize in medical school. They call it fair, fat, female, fertile, 40. And they're all sort of risk factors for possibly having a gallstone disease. And in this case, she seems fertile. She's above 40 and she's a female, which are all sort of risk factors for gallstone disease. These is not a handful way to diagnose or treat, but it's just something to keep in a history to maybe point us towards the right direction. So something to keep in mind. On examination, she's afebrile, she's tachycardic, her blood pressure is okay, her respiration is a little bit high, she's moving quite uncomfortably, skin's quite warm, there's scleral icterus, abdomen is quite soft, mildly distended with some right upper quadrant and epigastric tenderness. Bowel sounds are hypoactive, can't feel any masses or enlarged organs. So we do send off a test for occult blood and it's negative. Lab studies, total bilirubin seems to be elevated with alkaline phosphatase and AST, ALT all to be elevated. Serum lipase is elevated as well. So that's our key giveaway. Leukocytes increased with 82% of polymorphonuclear cells, and all her creatinine, her serum electrolytes are normal. They did an X-ray of the abdomen, have no non-specific gas pattern and no pneumoperitoneum, so rupture and gas in the peritoneal cavity, and a chest x-ray is normal. So what do you think is going on? So the most likely diagnosis, given all our issues, is pancreatitis. So there are several causes of pancreatitis. I get smashed is a good way to remember it. So I, idiopathic, G, gallstones, E, ethanol, T for trauma, S for steroids, M for mumps or malignancies, A for autoimmune, S for scorpion stings, H for high triglycerides or calcemia. ERCP is an important cause to remember, so we can actually cause pancreatitis by trying to image for pancreatitis. And it's due to the contrast dye that they use usually that injects into the biliary tree, causing the sphincter to be irritated and closed, and a lot of the pancreatic enzymes can't drain, causing inflammation of the pancreas. And some medications as well to keep in mind. So in this case, it's gallstones. So take some time to pause, but I think I've already went too far a little bit. But what would you image? And how would you go about it? And I think we've discussed that we'll do an ultrasound initially. And if we're thinking of any complications of pancreatitis, CT imaging as well. In terms of treatment, we're going to give her IV fluids for rehydration, analgesia as well. So it's all supportive measures. Studies haven't shown a role for prophylactic antibiotics or probiotics. And it's important to consider or monitor for complications. So shock, acute respiratory distress syndrome. And ultimately, we do need to remove the stone that's causing all these issues. So an ERCP with a papillotomy, so it's a small cut with a sphincter that can allow the stones to come out. And there's also some ways to actually go inside and remove the stones as well. And they're usually done after 24 to 48 hours after all the inflammation have settled. So that concludes today's session. Thank you for watching. Make sure to like and subscribe, and I'll see you guys next time.